Hi guys, in this video I'm going to explain in detail about biomechanics of your shoulder abduction, both your frontal plane as well as your scapular plane. So what are the difference between your frontal plane abduction versus the difference between your scapular plane abduction? So before going to the differences between your frontal plane abduction and scapular plane abduction, I would like to explain in brief about abduction movement of your shoulder. So what is abduction? So abduction is defined as the rotation of the humerus in the near frontal plane around an anteroposterior axis. So normally the healthy person has about 120 degrees of abduction at the glenohumeral joint. Full abduction, that is 180 degrees of shoulder complex abduction, requires a simultaneous approximate 60 degrees of upward rotation of the scapula. So in total, that is 180. In order to achieve 180 degrees of abduction, you need to have 60 degrees of upward rotation at the scapulothoracic joint and 120 degrees of abduction at the glenohumeral joint. 60 degree of scapulothoracic motion and 120 degrees of glenohumeral motions. That is your scapulohumeral rhythm. That is 2:1 ratio. And coming to the arthrokinematics of your abduction movement, so that involves the convex head. So this is the convex head of the humerus that will be rolling superiorly and sliding or gliding inferiorly. So abduction is accompanied by your superior rolling of the convex head with your inferior sliding or gliding of your convex humeral head. So these are the two diagrams in which they are mentioning what is going to happen. So if there is no gliding, inferior gliding occurs means only the rolling occurs means what are the changes that is going to happen in the coracoacromial arch or the shoulder complex area. So this is the diagram or model of the glenohumeral abduction movement without the inferior slide. So what happens? Only there is superior rolling. So without or in the absence of inferior slide, what are the changes that is going to happen? So you can see here, this is a model of the glenohumeral joint depicting a ball. So ball which is in the size of a typical adult humeral head rolling across a flattened glenoid surface. Based on the assumption that the humeral head is a sphere with a circumference of around 16.3 centimeter, the head of the humerus could translate around 1 centimeter after a superior roll of around 22 degrees. So the magnitude of translation causes the humeral head to press against the contents of the subacromial space. So this is the subacromial space. So abduction without a concurrent inferior slide causes the humeral head to impinge against the coracoacromial arch. So this is the coracoacromial arch and block the further abduction. So if only the superior rolling occurs means without a concomitant inferior sliding or gliding occurs means it will go and hit the coracoacromial arch and compresses the structures in between the coracoacromial arch, that is in between your humeral head and your coracoacromial arch, that is your subacromial space. What are the contents inside the subacromial space? This humeral head will go and compress. So if there is no inferior sliding means. So this is what happens if there is only the superior rolling possible without a concomitant inferior slide. So the arthrokinematics of this is the arthrokinematics of your right glenohumeral joint during an active abduction. So the supraspinatus is shown contracting to direct the superior rolling of your humeral head. The supraspinous pull of this main muscle, that is your supraspinous muscle pull, is responsible for your superior rolling of your humeral head, and your inferior ICL, that is your inferior capsular ligament, it also supports the humeral head like a hammock, and your superior SCL, that is your superior capsular ligament, this also remaining in a relatively taut position because of the pull from the supraspinatus muscle that is attaching over the area. So because of this, both your ICL inferior capsular ligament and your superior capsular ligament is tight along with your contraction of your supraspinatus pull, which is responsible for your superior rolling of the humeral head. So this is the diagram which I mainly focus to say about the associated movements that is occurring in the other joints also. So during your abduction, that is your 180 degrees of full abduction, you can see it is divided into 2:1 ratio. Two part given by your glenohumeral joint, that is 120 degrees of abduction, and remaining 60 degree will be contributed by your scapulothoracic upward rotation. So you can see here, this is the scapula is upwardly rotated, and this is the abduction. So at the end range of shoulder abduction, you can see here there is around 35 to 40 degrees of glenohumeral joint external rotation, along with your 5 degrees of external rotation occurring at the scapulothoracic joint, and the posterior tilt, that is around 20 degrees. and apart from that, other joints are also participating in order to achieve your shoulder abduction, that is 180 degrees of shoulder abduction. So this exact shoulder biomechanics abduction biomechanics will be taken in the another video. So you can see here 180 degrees of abduction that occurs as a result of concomitant joints motions. So mainly your external rotation of your glenohumeral joint. So coming to the topic, what is shoulder abduction, frontal plane versus scapular plane? So shoulder abduction in the frontal plane is often used as a representative motion to evaluate the overall shoulder function. Abducting the shoulder in the scapular plane, so scapular plane means that is 30 to 40 degrees anterior to the frontal plane, is a more natural movement and generally allows greater elevation of the humerus than abducting in the pure frontal plane. Furthermore, abducting in the scapular plane appears less mechanically coupled to an obligatory external rotation of the humerus. Attempt to maximally abduct your shoulder in pure frontal plane while consciously avoiding any accompanying external rotation. So if you try to avoid external rotation consciously while doing your shoulder abduction, what happens means the difficulty or inability to complete the extremes of these motions results in part of the greater tubercle of the humerus compressing the contents of your subacromial space against a low point on the coracoacromial arch. So it may lead to, if you are voluntary or consciously avoiding the external rotation at the end range, it may the greater tubercle may go and compress the subacromial space structures, that is mainly your supraspinous tendon and all. It may finally lead to impingement of those structures. So that is why at the end range there will be around 35 to 40 degrees of external rotation in the frontal plane movement. So for natural completion of full frontal plane abduction, external rotation of the humerus must be combined with the abduction effort. So this ensures that the prominent greater tubercles clear the posterior edge of the undersurface of the acromion. So if there is no external rotation occurring at the end range means it may definitely go and compress your acromial subacromial space structures and finally leads to impingement syndrome. So next, what is happening in the scapular plane? So fully abducting your arm in the scapular plane, the abduction movement can usually be performed with greater ease. So this scapular abduction movement can be usually performed with greater ease and with less external rotation compared with your frontal plane abduction, and at least in the early to mid range of your shoulder motion. So there will be less external rotation at least in the early to mid range of your shoulder motion if you are doing in a scapular plane, if you are abducting your arm in a scapular plane. So impingement is avoided because scapular plane abduction places the apex of the greater tubercle under a relatively high point of your coracoacromial arch. So in the frontal plane abduction, the apex of the greater tubercle is relatively less point at the lower point of your coracoacromial arch, whereas in scapular plane abduction, the apex of the greater tubercle is relatively under a high point of the coracoacromial arch. So scaption also allows the naturally retroverted humeral head to be oriented more directly to the glenoid fossa. The proximal and distal attachment of your supraspinatus are also placed in a straight line comparing with the comparing with your frontal plane attachments. So this is the difference between your frontal plane abduction and your scapular plane abduction. Scapular plane, higher part of your greater tubercle is in the highest position of your coracoacromial arch, whereas in frontal plane it is at the lower part of your coracoacromial arch. So this is the reason why impingement is less while moving in a scapular plane abduction comparing with your frontal plane abduction. So what is the difference between your frontal plane and scapular plane abduction is, frontal plane abduction is less natural movement comparing with your scapular plane, which is having a more natural movement, and it allows frontal plane abduction allows lesser elevation of the humerus comparing with the scapular plane, which allows greater elevation of the humerus. More mechanically coupled external rotation motion is occurring in the frontal plane, whereas in scapular plane less mechanically coupled external rotation movement. The range of external rotation is less in the scapular plane comparing with the frontal plane, and the lesser ease of movement in the frontal plane, whereas in scapular plane it is a greater ease of movement. And in frontal plane places the apex of the greater tubercle under relatively low point of the coracoacromial arch, which may lead to impingement syndrome, whereas in scapular plane it places the apex of the greater tubercle under relatively high point of coracoacromial arch, which reduces the chance of getting impingement. And in the scapular plane it allows a naturally retroverted humeral head to be oriented more directly into the glenoid fossa. So these are the difference between your frontal plane abduction and your scapular plane abduction. So why this is important? What is the difference between why this the knowledge of these two mechanical difference of these two frontal plane and scapular plane abduction is important? Because it is considered during evaluation and treatment of patients with shoulder dysfunction, particularly if subacromial impingement or supraspinatus tendinopathy are suspected. So, for example, in patients with this kind of issue, any shoulder dysfunctions, so if we are assessing the frontal plane, means they may have some, it may go for further impingement because it is going to hit the, because of the relatively less different distance between your tip of your greater tubercle as well as your coracoacromial arch, it may lead to further impingement. Whereas in scapular plane, it is relatively placed in the high end of greater tubercle is relatively placed in a high arch, high part of your coracoacromial arch. The chance of getting the impingement is less. So that's why while assessing the patients, we can try with the scapular plane abduction rather than your frontal plane abduction, which may exacerbate their symptoms. So try to, whenever we are assessing a patient, try to assess the patient in your scapular plane abduction as well as your frontal plane abduction. So thank you for watching this video. Please do share and subscribe this video to your physio friends and fraternity. Thank you.